is Stacy. I thought I would make some videos because I'm on vacation right now and needed something to do. So here is for your derm lectures. So I have the ones so far done from last week, and it's up on my drive. So we're going to go over acne and rosacea, pruritis, and urticaria and angioedema, and then bite stings and infestations, and then Pharm as well. Okay, so acne and rosacea. So acne development, I mean, most people know they either had it, they had friends with acne. It's usually between age 12 to 24, but it can even be up to age 40. There's an increased risk with the XYY karyotype, which is called Jacob syndrome, with PCOS, hyperandrogenism, hypercortisolism, or precocious puberty. So really just those like sort of reproductive hormone diseases can put you at an increased risk. So we know that like hormones play into this, into acne development as well. Especially testosterone. It occurs at the place of the hair follicle, and the path of this is oil production, abnormal keratinization, bacteria present, and inflammation. And the bacteria, and I would know this, is P. acnes or Propionibacterium acnes. So, types of acnes, we have open comedo, which is the blackheads, which have that dark look to them. They're dilated central openings and they're filled with keratin. We have closed comedos, which are whiteheads, so they have that flesh that goes over them. They're kind of a 1 millimeter flesh colored papule. We have papules that is less than a centimeter and it's erythematous. Then we have pustules, which are pus-filled papules, basically. And then we have nodules, and they're going to be greater than a centimeter. They're deep, they're palpable, and they lead to scarring. The other type of sort of acne that we have is going to be hormonal acne. So usually it's women between ages 20 to 50. It's associated with PCOS and elevated testosterone. It's usually at the jawline. There's inflammatory papules, pustules, and cysts. Treatment is going to be basically getting these hormones under control. So oral contraceptives and anti-androgen medication. If it's severe, start looking for a hormone-producing tumor. Okay, so we've got some degrees of severity, mild, moderate, and severe. So usually our mild acnes are mostly comedones. Moderate, we've got comedones and then papules and pustules, and severe is going to be mostly the scarring nodules and cysts. So treatment, and I think that this is really important to know, the treatment for mild, moderate, and severe. So mild, we're going to start with benzoyl peroxide or salicylic acid, and then we can add a topical clindamycin. Moderate, we're going to do the benzoyl peroxides and our topical clinda, and then we're going to add a topical retinoid. Then after, let's say that doesn't work, we're going to add PO doxycycline. So we've done benzoyl peroxide, we've tried a topical antibiotic, we've tried topical retinoids, it's still not working, and we're adding that oral antibiotic, and maybe it's still not working. Well, let's see, is this hormonal? If it is hormonal, remember, it's near the jawline. Let's try to fix the hormones. Let's get on some anti-contraceptive, or let's get on contraceptives. And then also maybe try spironolactone, and that can help as well with that anti-androgen effect. Accutane also is our last ditch effort. It's really a treatment, the treatment for acne, because it treats all parts of acne. However, it does have some side effects, and it is sort of like our big gun. So it's a little scary. Okay, so let's look at how this stuff works. So salicylic acid accumulates in the sebum glands. It's anti-inflammatory. Benzoyl peroxide is bactericidal. And then, of course, clindamycin is an antibiotic. We'll just keep going through how it works. So retinoids they normalize follicular keratinization and enhances MMP. So the cool thing about retinoids is that it actually helps wrinkles too. So some people get that for wrinkles because of it enhancing those MMPs. And it also enhances the topicals like benzoyl peroxide. Doxycycline suppresses that P. acne and is anti-inflammatory. So spironolactone is a 5-alpha reductase inhibitor at the follicle. It decreases sebum. And then isotretinoin, it affects sebum and keratinization and bacteria. Okay, so let's go to the side effects. So with the side effects, benzoyl peroxide, salicylic acid and clindamycin can be dry and irritant. Benzoyl peroxide, it's got peroxide in it, so it can bleach your sheets and towels. Clindamycin has a risk of resistance and is decreased. That resistance is decreased when it's combined with benzoyl peroxide. So it's always important to combine it with both of those. Retinoids increases sensitivity, increases burning, irritation. Doxycycline has that, remember, sensitivity, also nausea and pill esophagitis. So our Accutane, our isotretinoin, dryness, it can elevate your liver enzymes and it can elevate your LFTs and your triglycerides. Yeah, so your liver function tests and triglycerides go up, so that's not good. Also, it can alter your night vision, and it's really important with female patients that they get weekly pregnancy test because it is a teratogen. Okay, so I would know these, and I would make sure that I knew the treatments for each, and probably the side effects. Okay, so nowhere in those treatments do we see that we need to be popping our pimples. Okay, so let's go to rosacea. It's a persistent erythema of the cheeks and the nose, which is greater than the forehead and chin. Telangiectasias might be present, flushing, and erythematous papules and pustules. So usually the vignette is going to be a woman from age 30 to 50 with fair skin. The path of this is going to be UV light, vascular changes, epidermal barrier dysfunction, microbes, and immunity. So types of this is going to be erythema telangiectasiatic, papulopustule, and then glandular rosacea. So when I put this on the slide, I thought, what is a differential maybe that has a similar face rash that we need to make sure that we do not associate or know the difference between rosacea and this rash? Okay, so it's systemic lupus erythematous, SLE. So they've got that butterfly rash, and so this isn't exactly it. There isn't any on the nose in rosacea, and then it also doesn't have all of that. It's got telangiectasias here with rosacea, and it's always present, and they don't have any like systemic things going on. So let's look at the types. So erythromatogenic is going to be flushing with that persistent erythema and telangiectasias. So that's shown in the picture. Some triggers for this are going to be alcohol, spicy food, heat, sunlight, when cold, or exercise. So how do we treat this? We're going to kind of like avoid some of our triggers. And then like with the sunlight, we're going to use sunblock. Using a green tinted makeup can Green and red are opposite on the color wheel, so it can cancel kind of each other out. And then avoid the flushing using, avoid alcohol, avoid spicy food, and so on and so forth. Okay. Papulo Pustular is going to be erythematous papules with pustules on the central face with that background of erythema. So this looks very similar to acne, but it's not. So the whole trigger of this is it's actually a dermodex mite. And so this can actually be treated with topical antibiotics, but permethrin to kill the mite. So if they have this papulopustular rosacea, make sure that you treat it with permethrin. Okay, and know that it's going to be mostly on the cheeks and nose, where acne is going to be more on the forehead and chin. This is mostly going to be the cheeks. So usually acne doesn't start just at the cheeks. So know that. Okay, so phymatis or rhinophymatis are usually in men. So most of the rosaceas are in women, except this one's in men. It's thick, sebaceous, nodular skin, usually the nose, and that's when we add the rhino to it. Nodulocystic lesions, and they have prominent pores. So the only way to really fix this is surgery, and it's specifically loop cautery. So if you want to like check this out, they've got like videos online, and I'll show you how they fix the nose, which is kind of cool. Ocular. They have blepharitis, recurrent chalazion, conjunctivitis, and that dry, gritty sensation. So our treatment here is going to be oral antibiotics. Okay, so let's look at some of the pharmacology. So cellulitis, outpatient, think of like antibiotics. Think of things that that protect against MRSA. So like Bactrim, TMP-SMX, doxycycline, minocycline, clindamycin. And then our last ditch effort would be Linezolid. So I would know that we've tried other things. We can't go to the cellulitis, go to Linezolid. Purulent antibiotics for non-purulent cellulitis should provide against beta hemolytic strep. So, so the difference is, so if it's purulent, we've got pus associated, then we start going against MRSA. So TMP-SMX, doxycycline, minocycline, clindamycin, last ditch effort, Linezolid. If it does not have pus involved, then we need to think about beta hemolytic strep. So Keflex, ceflexin, or amoxicillin. Let's say it's non-purulent, but we think MRSA. Then go to like a beta-lactam and TMP-SMX or tetracycline, or you can go to Linezolid or clindamycin. Community-acquired MRSA, how do we get that, Gems? Okay. In patients, hospitalized patients with complicated purulent cellulitis should get an IV antibiotic with activity against MRSA, like vancomycin or clindamycin or Linezolid. That's the main three I would think of, but also like Dapto and Vancin. Okay. What are some side effects? TMP-SMX, don't use in pregnancy, don't use in patients with G6PD, but also know that it could cause Stevens-Johnson syndrome. So know that those are related. Doxycycline, we had already talked about. It's one of the sun fries. So it has sun sensitivity. Clindamycin can lead to C. diff. Linezolid can cause serotonin syndrome. So let's think about that there was a patient, let's say that they were on like an SSRI, and you gave them, it was like your last ditch effort, you gave them Linezolid for purulent cellulitis, and they developed this serotonin syndrome. So know that Linezolid is a cause of that. That's what I would know for cellulitis. So diabetic foot, always think, okay, we've got to give on broad spectrum antibiotic, and but you don't have to treat against Pseudomonas unless they're having specific risk factors like soaking their feet, failed other antibiotics, or it's a very, very severe infection. So pseudomonal and anti-pseudomonal antibiotics would be cefepime, Cipro, cefotaxime, and aztreonam. Okay, so our prophylaxis is going to be preventing infection by reducing the burden of microorganisms at the site, like cefazolin. Okay, so acne. We've talked about that. Vitamin A derivatives is our topical retinoids. Besides doxycycline, you can also use minocycline. Just absolutely know with our isotretinoin, high risk of severe birth effects, and it reduces sebum production, reduces keratinization, and kills the bacteria. Okay. Some topicals that we have: lidocaine jelly, cream jelly lotion. It blocks the initiation and conduction of nerve impulses by decreasing neuronal membrane permeability to sodium ions, and it results in inhibition of depolarization with a blockade of conduction. So know that. And then I think to know, like, topical tacrolimus is a calciurin inhibitor, and it's an alternate for corticosteroids in thin skin. So let's think about, like, I would definitely probably know that one. Think about thin skin like your face or like an eyelid. So let's say you've got a really bad rash on your eyelid. Tacrolimus would be a good drug to give. All right. So Stevens-Johnson syndrome, we said that sulfa drugs like TMPSMX can cause it. Also penicillins. A way to remember the different drugs would be scalpel. And some of our things are like antibiotics, penicillin, sulfa, NSAIDs, anticonvulsants like phenytoin, carbamazepine, lamotrigine, and then I think allopurinol. That would be like the ones I would remember. SLE-like syndrome will be our SHIP-E drugs, like sulfa, hydralazine, isoniazid, procainamide, and Teracept. So SHIP-E. Okay. As well as like, so anti-histone antibodies. So it sort of creates this perfect storm. So photosensitivity are going to be our sunfries, one of the sunfries, tetracycline, sulfamides, and fluoroquinolones, the sunfries. Drug and virus equals eruption. So think about a child or an HIV patient taking TMPSMX, and then they get Stevens-Johnson syndrome or TEN. Okay, so this is all of our Pharm, the Pharm lecture. Also, just to note, at the very end, I put a like sort of a review antibiotic guide. Okay, so let's talk about itching and angioedema. So etiologies of Pruritis. So we've got atopic dermatitis, which is a pruritic area where a rash appears, allergies, rhinitis, asthma. It involves the flexor wrist and ankles and the antecubital popliteal fossa. So that's atopic dermatitis. So a good example of this is like showing you exactly where a watch band appeared or a belt, for instance. And they like, you've got this belt, they push down their pants a little bit, and then you can see the outline of the belt. So like maybe they were reacting to metal in it. Dermatitis herpetiformis, I would 100% know this. It's a rare vesicular dermatitis that can affect the spine, elbows, and knees. Remember, it's associated with celiac disease, and we talk about that in the GI lectures. Urticaria or hives are intensely pruritic, well-circumcised, erythematous, elevated wheals, and they can wax and wane. It's associated with a mastocytosis, medications, and allergens as well. Treatment is going to be a H1, H2 blocker, corticosteroids, and sometimes epinephrine if it's bad enough and causing throat swelling. So systemic causes are going to be hemochromatosis, biliary cirrhosis, hepatitis, chronic renal disease, as well as pregnancy. Okay, angioedema. So a lot of the times when we talk about angioedema in like pharmacology, we're talking about it could be a reaction from ACE inhibitors. So it's that local non-pitting edema. Usually I think of like big tongue swelling, lips, but it can also be eyes. It can be warm, painful, remember, rapid onset. Can also affect the genitals and the extremities as well. So there's two different types. There is an activation of mast cells, so kind of like an allergic reaction to foods or medications. And then, or it's that generation of bradykinin, and that is our example, like our ACE inhibitors, or if somebody has C1 inhibitor deficiency. Also, it could be idiopathic. If the airway is compromised, make sure first thing that we do, we're going to intubate the patient. With that throat closing, you may need assistance. So treatment is going to be epinephrine and stop that ACE inhibitor. Antihistamines and steroids are another thing. Okay, so last lecture for today is going to be bites, stings, and infestations. So I thought that these were a little bit like difficult to know what would be important, but I tried. So mosquitoes have that local reaction of a will flare, pain, pruritis, and erythema. Know that they can carry diseases like our encephalitis and our arboviruses. Prevention, don't travel to the fun places, like don't go to like Florida or the Caribbean. Reduce larval habitat. So get rid of standing water. Like if you, let's say you live in an area, let's say you live in Florida. If you have like a pot that has standing water, this is a perfect place for mosquito larvae to live. So get rid of that. Make sure that there's no standing water near your house. Insect repellent with DEET, as well as mosquito nets. Ticks. On a skin exam, make sure that you look for punctures, mouth parts. Get that mouth part out if you find a tick. Primary concern is going to be our Lyme's disease, Rocky Mountain spotted fever, or ehrlichiosis, tularemia, and babesiosis. And remember, our treatment for these diseases is going to be doxycycline. Okay, fleas and flies. Black fly is intensely itchy. It can cause angioedema and even anaphylaxis in some cases. It can also cause fever, leukocytosis, and lymphadenitis. Horse flies are going to be painful bites, necrotic reactions as seen right here, and can cause anaphylaxis. Sand flies are painful bites located in the Middle Eastern tropics. The tsetse fly, it promotes that African trypanosomiasis or sleeping sickness. A patient presents with canker, intermittent fever, lymphadenopathy, anorexia, CNS symptoms, convulsions, coma, death. Fleas are usually okay, but they can transmit the Black Plague in areas that's common. How do we prevent fleas? Vacuum, wash clothes, just basically clean your stuff. Okay, creepy crawlies, the caterpillars and centipedes. Centipedes are very venomous in Asia, South America, Australia, and Hawaii because they immobilize their prey. It's very painful, rarely causes necrosis, but could cause a heart attack or rhabdo. Treatment is going to be analgesics, antihistamines, ice packs, and an EpiPen if needed. Caterpillars leave that tram track pattern So look at your slides for the picture of that. I should have included it on the slides. But it has that tram track pattern of hemorrhagic macular papules and a wheel flare. So I feel like if she showed you a picture and said like what bit this patient, like that would be something pretty easy to get. Lonomesum is from South America. It can cause dizziness, nausea, vomiting, abdominal pain, epistaxis, hematuria, and renal failure. There is anti-venom that you can give these patients, but make sure that you do not give them blood products. So if you see, this is kind of like, I think, kind of weird symptoms. So know that it's associated, that abdominal pain, dizziness, and bleeding, it's associated with lonomycin, and we can't give them blood products. So I think that could be an easy question. So spiders, we've got the widow's yellow sac-brown recluse. Usually they blister, have a pale center, purpura, or they could have that central necrosis. So think about it. When you're asking yourself, is this a spider bite? Look for clues. And this was also important in the Pharm lectures. So is this in the AC faucet? Is it going along the track of a vessel? If it is, then most likely it's not a spider bite, even though the patient's like, oh, I got bit by a spider. It's probably not a spider. It's probably MRSA, and it's probably due to IV drug use. So our treatment here is going to be vancomycin. So stinging things, bees, wasps, ants. The fiery ones shown in the picture, they're pretty scary. So reaction is going to be redness or swelling. Here's blistering. Yellow jacket stings are more likely to get infected. So make sure to keep those clean and treat as necessary. And it can result in anaphylaxis in some cases, especially if a patient has an allergy. It's IgE mediated, and it responds because your body's responding to those venom proteins. Treatment is going to be an EpiPen if they become anaphylactic, and then steroids. For everything else, cold compresses, anti-itch creams, antihistamine, steroids, NSAIDs, clean sites. A toxic reaction of several stinging things would be renal failure and cardiac events. Okay, some more annoying bitey things are going to be scabies. So scabies are going to be usually females. They mate and burrow into the epidermis and can survive up to over a day. They lay 2 to 3 eggs at a time in the epidermis. Symptoms, it's going to be these breakfast, lunch, and dinner bites. So you usually see like 3 bites in a row. They're going to burrow and kind of go into lines, and they look for hiding places. So extensor and web spaces of the fingers and toes. So I think if there's a question, it's going to show you some fingers like this. And if I think somebody has scabies, I always look in between their fingers. And they can also crust as well. So look for this burrowing. And how do we diagnose would be with an exam, skin scraping, microscopy. Treatment is going to be permethrin, ivermectin, or nitroba. And you need to treat everybody that they're involved with because they probably have scabies too. So complication, it can get infected, staph strep. It can lead to sepsis, and it's super itchy. So remember, not dermatitis herpetiformis because it is not blisters, and these aren't like in a row, and it's not acroplosis, which is sort of like it's like newborn infants, and looks like pustules. So know that it's like burrowing and it's like between the fingers. Okay, more biting things, bed bugs, Simix litularis and Simix hemipteris. They feed on host blood. It lives in cracks and crevices like mattress, couch, pore area, places of travel. Symptoms are going to be painless bites on skin in a linear pattern, 2 to 5 millimeter erythematous papules or wheals, and urticaria, and IgG previously exposed. Treatment is going to be supportive, pest control, get rid of these bad guys, and then prevention. So make sure that like when you're traveling, maybe to look under the bed. Okay, Our last slide today is going to be lice. Pediculosis humanus capitis. Children are most likely infected. It's spread by direct contact. Symptoms are going to be pruritis due to allergies to saliva and excoriations. They're really difficult to remove from the hair shaft. And so this is different from other things. It's not hair cast because they're really easy to remove. It's not pydra, which is a fungus. Make sure that you know they're really hard to remove, and that can clue you in that it's lice, and it's usually kids, and they get it from like school. So treatment: wet combing, permethrin, or spinosad. So something else that wasn't in the lecture, but little like side note, if you have kids, maybe. In kindergarten, they told us to like that tea tree oil actually like prevents lice. Lice don't like the smell of it. So like every day, like my mom got some like tea tree shampoo and conditioner, and that's what I used. And so kids in my class got lice and I did not. So and they they do not like clean hair. So like I washed my hair every day with this tea tree shampoo. So I don't know. It's a thought. All right. See you next time.